Good afternoon, ladies and gentlemen. It is genuinely a pleasure and a privilege to be here talking to you and seeing so many friends and colleagues and my gurus in the hall. I initially thought I was going to talk about transition generally as a life phase, and then I thought I was going to talk about transition in healthcare systems, and I've ended up, I'm going to talk about both. So you're getting two for the price of one. Is there a timer that I keep an eye on? Yeah. There is a place in India, northeastern India, called Bihar. It's a feudal state, very, very poor. It has a small rural area called Gaya. And 2,500 years ago, Gautam Siddhartha was sitting under a tree called the Bodh tree, and he attained enlightenment, and he became Gautam Buddha. So the place is now called Bodh Gaya. If you go to Bodh Gaya now, young people from that rural feudal background live the same lives as were lived 2,500 years ago. And they are still constrained in rigid social structures. The reason why I'm saying this is that this morning somebody asked about young people in low and middle income countries. So we have to be aware that quite a lot of what we talk about here is restricted to a section of young people. And the challenges faced by vast majority of young people in large parts of the world are different. And I'll try and come back to this because we've just started a big program of work in low and middle income countries on early intervention. If I have time, I will mention it. In Germany, there is a term called Sturm und Drang. I don't know if I'm pronouncing it correctly. It was a romantic philosophical movement, literary movement in the 18th century. And Sturm und Drang means storm and stress. And in the 20th century, it became a popular term among psychologists to describe teenage years. So the idea was that teenagers are in a phase of storm and stress. They are reckless, moody, ticking time bombs who can go off at any moment. And this was a very popular view, and it was widely held. And then Margaret Mead, who was an anthropologist, went to the Pacific island of Samoa. And she wrote a book called Coming of Age in Samoa. And she described how young girls in Samoa seamlessly moved to adult roles with no period of transition or preparation. And she argued that this whole idea of teenage and transition from child to adult role was not really true for large parts of the world. And again, so you had these two contrasting views of adolescence being a specific phase with transitions in many areas, to this idea that actually that's not a human universal. My mother was 13 when she got married. My father was 18. Neither of them had attended school. They were very poor. And she became a mother at 15. And she had I don't think she had a teenage years. And by the time I was 3, my mother was a grandmother. So I was brought up by a series of older sisters. So I had my mothering changing from sister to sister as they got married. They'd be married off, and the next one would take over looking after me. So even 50 years, but not even 50 years ago, even 40 years ago, there wasn't a sense. But you can see between my mother and my eldest sister, there were only 15 years, but my eldest sister went to university. So she had a period of transition from being a young girl to a woman. And now we have this interesting idea promoted by Jeffrey Arnett of emerging adulthood or extended adulthood. It was a paper that came out in 2000, and Time magazine picked on it, and it suddenly became all a rage. It got 6,000-7,000 citations, and there's an international society for study of emerging adulthood. And the idea is that young people now have a long period of possibilities. So they can experiment with their work, their identity, their intimate relationships, their studies. They stay longer at home, and they delay taking on adult roles. Now, to be fair to Arnett, he did say in his early work that this probably applies to a particular section, even in the West, people rich enough to have kids at home. Probably not true for a lot of working class population in Britain, but it's an idea that's become very popular. And so I take you back to my mother and young people in Gaya, Bodh Gaya. And I think we have to again be aware that perhaps these are culture and context specific phenomena, and perhaps not human universal. I may be wrong, but I don't think these are necessarily human universals. They are in a particular context, in a particular stage in the development of the West. The other thing is that this period, even if it's culture specific and context specific, definitely does exist. There is definitely change, and even in Bodh Gaya, there is now rapid change, as there is in India. So what you have is the downside of that plethora of possibilities. You have the tyranny of choice. Young people now, and we know, quite sound behavioral psychology research, too much choice is stressful. This morning, Pat McGorry was saying the amount of anxiety in young people is increasing. And some of it, you can see, is related to the dismantling of the scaffolding that society has had about young people. So my parents had a very rigid, unyielding path. It would be simplistic to say it was a patriarchal society, because my father also had no choices. So those are not patriarchal society, that there were rules governed and rigidly bound in what your social roles were. And so that was probably true in Samoa, that's probably true in many parts of the world. And that in the West, in quite one or two generations, post-World War II, that has dismantled. And I don't think we have found a way to create a responsive, flexible social structure that supports our young people as they go through these very new challenges, which are probably unprecedented. My daughter is 18. She has 4,000 friends on Facebook. You can't have 4,000 friends. Some of it is, it's almost an anesthetizing against the pain of human relationships. It's fake, it's illusory, it's transient. Everybody seems to be living endlessly exciting lives. It's envy-inducing. So they have new challenges, and I don't think we have sorted out how to, as a society, allow them the freedom to experiment, but give them the comfort of containment. Containment is important for young people. And I think we may have stopped containing them a bit too much. Although it may be just my struggle with my 18-year-old. You may all be doing a very good job. So how does that, and let me try and bring it to transition in healthcare, which was the original title of my talk. How does that work? What is the problem in transition in healthcare? Well, the first thing is it's a big problem. There is a problem, and the problem is that, at least in USA and UK, 50% of young people who reach the boundary for child services do not make it to adult services. So, now, not all of them need to, but a lot of them do. And we don't know what happens to them. So like the strum and dang, even in transition in healthcare systems, the journey is turbulent and the destination is unknown. So they really don't know where they're going, and we don't know where they go. At a national level, the numbers are significant enough for you to be alarmed. But at an individual service level, the numbers are small. So a small CAMS service in Britain will have 6 to 10 kids per year who will reach a transition boundary. And in a service that's looking after 300, 350 kids, this is at best a minor irritation. It's not a huge problem. And for the adult services, it's a complete irrelevance. It is good that these kids don't come to them because it manages a caseload. But for each of those individual kids, it's a huge challenge. And we've seen work earlier today, and we published on it. It's a fairly major issue. And going back to the other transitions, they're also, while they are navigating this system, they're also going through all the other challenges that I told you about, intimacy and work and independence and going to college or leaving home. So all of those, it is a very turbulent journey with an unknown destination. I don't know how better to put that. But of course, because it's at an individual service level, it's a small problem. There is not much incentive for services to do something about it. We conducted a review for NICE. NICE is the organization in Britain that looks at all important relevant clinical issues and sees what works, what doesn't work, and what are the cost benefit of various interventions. So I was lucky enough to chair the NICE Guidelines Development Committee on Pediatric to Adult Transition. This was not mental health specific, it was across the board. And as a part of that 2-year process, we looked at evidence from all over the world, published evidence, grey literature, and expert opinion. And we found that there is not a single model of transitional care that has been robustly tested. And there is zero information on the health economics of transition. What is the cost of poor transition? What are the costs and what are the consequences? We really don't know. Quite astonishing. We really, really don't know. What we have is individual models that people have tried. So these range from joint clinics to transition workers that work across services, to bridging services, to some recent examples of using social media to maintain continuity. But the idea is that young people going through need continuity of care. And a lot of these models come not from mental health, but they come from cystic fibrosis, leukemia, juvenile onset rheumatoid arthritis, early onset diabetes, chronic conditions where people need ongoing care. Regardless of the speciality or the disease, the problem of transition remains the same. We seem to have two subcultures in medicine, the subculture of child medicine and the subculture of adult medicine. In mental health, these seem to be really far apart. They are conceptually and clinically very, very different. In diabetes, at least, both child and adult diabetologists know that the child needs insulin. In psychiatry, in mental health, we can't even agree on what that young person needs. We can't even agree on how to assess them. So the divide is particularly big and unhelpful in mental health. What we found was that, again, wherever you look at the transition problem, the individual undergoing that transition tends to suffer. They tend to feel neglected, forgotten, abandoned, or ill-prepared, at best ill-prepared. The best services where people have managed continuity of care, young people will still say, we were unprepared for this. We weren't really told. We weren't told alternatives. So what can we do about this problem? The first thing is that if it was a simple problem, somebody would have solved it by now. And nobody has. So I don't have a solution either. We have some examples. So in one of the areas, I can't remember, might be leukemia. In one of the areas that we looked at, there was an evidence of a one-page portfolio. So what the child clinicians did with a young person approaching transition was they created a one-page portfolio of the child's problems and needs and preferences on a single page, which was kept by the young person and taken to the next service who had an advanced copy. Because the young people would say, we really don't like telling the story over and over and over again and starting afresh. Why can't the information be passed? So that seemed to work. Another thing that seemed to work was an early transition planning. Now, if you know your age boundary, if your age boundary is 18, then you know next year everyone in your service who was born in 2000 will reach a transition boundary. You can predict it 10 years in advance. And yet we had 3 years ago in Britain a case of a young girl who was on a child psychiatry ward. On the day of her 18th birthday, the day before her 18th birthday, she was told she was going to an adult ward. She went to an adult ward. A week later, she hung herself. And her parents are utterly distraught. And what is the rationale for telling her on the day before when you could have predicted it years in advance? So in the NICE guidelines, what we ended up saying was that the earlier you plan, it's better. So in UK, for children with special needs who are going to need ongoing special needs education, there is a legal requirement to start transition planning at 12 or 13. But in mental health and in physical health, we felt that about a year before the young person is reaching the transition boundary, you should start thinking about it. So this is a simple thing that we can do. So you have the information in the young person's preference of their needs and their strengths. And we also said it should be individualized, but it should not just be based on needs. It should also be based on strengths and abilities, because part of the transition is making them independent so they can self-manage their condition. And they want to detach themselves from their parents. They want to be autonomous. They want to take more control over their treatment. So an early planning, a very patient-centered planning, person-centered planning, developmentally appropriate. Two young people at 18 may be very, very different in their developmental abilities. So developmentally appropriate. None of this is rocket science. So you can read the NICE guidelines. They're fairly straightforward. There was a paper out of those in the BMJ last year. Very straightforward things. I don't think we need extra resources for this. We don't need new people working on this. This is simply good practice that should be implementable. What stops us from implementing it? I go back to my original point. It is at its individual service level. It doesn't seem to be a big problem. And adult services don't see it as a shared problem. And our big challenge is getting people from adult services seeing it as a shared problem. If they don't see it as a shared problem, they don't join in, and the young person is left struggling with child psychiatry services. So and so what we have to find a way, just like I was saying, society has to find a way of building soft, malleable, yielding, responsive structures around young people during their transition phase. We have to do something similar in mental health. And paradoxically, to make them autonomous, we have to hold them by the hand through this journey. And it's an interesting paradox. You have to help them along in their autonomy. You can't just let them fall off the cliff edge. They will not become autonomous and they will suffer. You can't keep containing them. You can't. Some camp services hold on to young people because they think adult services won't work. You can't do that. So it's a tricky balance, as is everything interesting in life, to make them autonomous and independent while guiding them. But I don't think I have a simpler answer than that. Thank you very much for your attention.